So we're going to dedicate a few minutes just to talk about special situations in the patients with Barrett's esophagus. So Barrett's esophagus, as you learned earlier, is a complication of acid reflux. So long-term acid reflux could lead to damages such as Barrett's esophagus. So now we have a patient that has Barrett's esophagus and continues to have acid reflux. So the patient still has acid reflux. Now we have two entities to treat, the Barrett's esophagus and the GERD. So what we do in these situations is that we categorize where the patient is at with regards to the Barrett's esophagus. So we may have some differences with gastroenterologist colleagues in terms of how we treat Barrett's, but our goal is ultimately the same. So this is where the differences and similarities stand. So I am a surgeon, so I like to correct the reflux whenever possible because that's what leads to the Barrett's esophagus. But it is okay to observe Barrett's that is non-dysplastic or has not changed to a more severe status. If you have a short segment Barrett's and you still continue to have reflux, it is prudent to have anti-reflux surgery. What we see in those patients is that the Barrett's tend to regress in up to about 20 or 30% of the patients. And in the other patients that the Barrett's still has not regressed, we can continue to surveil. The way we surveil Barrett's is by doing an endoscopic visualization periodically and make sure that it's not changing or increasing. So now what happens in situations where Barrett's is a bigger problem? That means you have a longer segment of Barrett's that is affected, or you have Barrett's that is changing, and that means is developing dysplasia, progressing towards cancer. In those scenarios, we have to treat the Barrett's first. So we do treat the Barrett's by inserting special camera into the esophagus, and we tend to ablate or burn the areas that have changed. We place the patient on an optimal anti-reflux therapy medication while we'll surveil the Barrett's. There are instances in which we have to do repeated therapies to burn the Barrett's completely. Once we have achieved Barrett's ablation, it is the recommendation that you get complete treatment for reflux. And I do prefer anti-reflux surgery rather than continuing with medications. And the reason why I said that is because the studies have demonstrated that patients that take treatment for GERD with medications do not particularly get any protection when it comes to Barrett's progression or when it comes to developing Barrett's, whereas patients that have anti-reflux surgery have greater benefits in the long term. So what do I mean by burning Barrett's? Burning Barrett's means that you have a very soft plaque instrument that you put up against the lining that has changed. Now this gives you a very controlled heated temperature. It does not go deep into the tissues. It just goes into the lining that is affected. So what we tend to do is that we scrape that surface off. Then your own body regenerates that surface into a normal lining of the esophagus. This is what we mean by burning or ablating Barrett's esophagus. So this animation, we're going to make it out of one of the most common therapies, which is called radiofrequency ablation therapy. There are multiple other modalities to treat Barrett's esophagus that we're not going to cover today, including cryotherapy, photodynamic therapy, endoscopic mucosal resection. We're only going to present briefly the presentation on radiofrequency ablation because otherwise the topic will get way too broad. So here's an example of how the radiofrequency ablation works. So in this animation, we demonstrate how we pass the catheter. This is a demonstration of a 360-degree catheter. That means it's trying to ablate the Barrett's all around. So the scope could help us see the area that we're treating. We're trying to make that area of Barrett's esophagus return to the normal tissue. After we ablate the surface of the esophagus, we tend to scrape off that tissue that we don't want in the area. And then we repeat the treatment another time for a second cycle. Please bear in mind that the esophagus regenerates quite fast. So almost all of the work that we've done here, it won't be noticeable in a matter of 1 to 2 weeks. So we do repeat the endoscopies periodically just to make sure that the area of Barrett's is disappearing. So this may require several sessions until we have completely eliminated the Barrett's surface mucosa. So if you do know you have Barrett's esophagus or you suspect that you may have Barrett's esophagus, it is very important to schedule a consultation so that we can discuss all the details.